So welcome to this webinar, everyone. Apologies for starting slightly late. So we've got a series of 5 lightning talks for you today, all around shaping the future of brain health, dementia prevention and future care needs. This is part of a series of webinars hosted by the NIHR Policy Research Unit in Healthy Ageing, of which I'm a director. And this particular webinar is co-hosted with our colleagues from the Policy Research Unit in Dementia and Neurodegeneration from Queen Mary, University of London. So we've got 5 varied talks today that have used different research methods. We'll start with attitudes towards brain health and dementia risk reduction among minoritized ethnic communities in the UK. Then go on to talk about the Nottingham consensus on dementia risk reduction, and then preferences for new models of care for people aged 50 plus with high care needs, some reflections on the meaning of quality in home care, and then finally a talk about the potential content for a minimum data set in home care. We expect that this will last around 45 to 50 minutes maximum. Each speaker is going to speak for around 7 minutes, and we'll have a maximum of 2 questions after each talk. Could I ask throughout if you want to put your questions into the Q&A function or the chat that you'll see at the top of your screen. We would prefer you to use the Q&A, but sometimes that it doesn't work well depending on your browser. So we'll monitor both the Q&A and the chat, and we'll pick out a couple of questions to put to the speakers. The remaining questions we'll aim to respond to and circulate a written response after the webinar. So I think the next thing really is to introduce the first speaker, who is Nahid Muqaddam from Queen Mary, University of London.
Hi, thanks so much for hosting me. So I'm going to be presenting the work that we did looking at attitudes towards brain health and dementia risk reduction amongst minority ethnic communities in the UK. Next slide, please. So we all know dementia prevalence is increasing and that there's been growing interest in prevention, as at present there are no disease-modifying treatments that will effectively cure the disease. So there's been growing interest in potentially modifiable risk factors, but we know that also some groups, particularly from minority ethnic backgrounds, are at higher risk of dementia, but tend to be underrepresented in research. And also there is a stigma and limited knowledge around prevention. So we wanted to do some work to explore ethnic differences in knowledge around dementia. Next slide, please. So far, most dementia risk research is focused on people of wide European origin backgrounds, and it was important to understand how different communities perceive dementia and brain health. So we aim to explore attitudes to dementia prevention, stigma, and also knowledge about dementia and brain health to inform future targeted prevention strategies. Next slide, please. So we used 2 large UK-wide surveys that were commissioned by Alzheimer's Research UK. This was over 3,500 people in total. These were conducted online and also via telephone between 2003 and 2004. And the questions were that they asked the public were around knowledge about dementia, and then stigma, so whether they would be willing to discuss symptoms of dementia with anyone else, and then whether they thought dementia risk could be reduced. And then there was other questions around awareness of brain health and lifestyle risk factors. Next slide, please. So what we did was conduct regression analyses. The main exposure with it was ethnicity divided into white, South Asian, Black and other. The other group was obviously quite heterogeneous, although we included these in regression analyses, we didn't comment on the results because they were too heterogeneous. The group is too heterogeneous to comment, and White, South Asian and Black are the main ethnic groups in the UK currently according to the latest census. The main outcomes we were looking at were knowledge about dementia, stigma, belief in dementia risk reduction, and then awareness of brain health and lifestyle risk factors. We just adjusted all of the analyses for age, sex, social grade, education, having a chronic health condition, and knowing someone with dementia. Slide, please. So what we found was that South Asian and Black participants had lower dementia knowledge and higher stigma than people from white backgrounds. And despite these groups having higher education and social grade, there were still gaps in dementia-specific awareness. Their general brain health knowledge, like around sleep and diet, was stronger than dementia-specific knowledge. So I think what this showed us was that that people understand dementia risk and brain health as separate entities, even though people in the research field will often think about them in this, as being the same construct. Next slide, please. And that, given that a lot of the sample had quite high education levels, just sort of having higher levels of education doesn't reduce stigma. And we need to think about also the cultural relevance, the language that's used around talking about dementia. Women reported higher stigma, and people who were in contact with someone or knew someone with dementia, they tended to have lower levels of stigma, but contact with people with dementia was lower in minority ethnic groups. And having a chronic illness was also linked to lower dementia knowledge. So we need to think about how to, how to make sure that we're getting the message out there that it's preventable and that it is as brain health. Next slide, please. We're also aware that there are factors linked to digital exclusion, including ethnicity, lower education, and chronic illness. So without any adaptation, these digital tools, or even surveys, may exacerbate disparities rather than reduce them. Next slide, please. So what our findings highlighted was that having a one-size-fits-all approach is unlikely to succeed, that we need to be thinking about co-designed, culturally tailored and intersectional strategies, and that perhaps thinking about integration of dementia education and awareness into chronic care, community spaces, and gender-sensitive platforms is important. And also we need to think about how to frame the messaging around, brain health being the same as protecting against dementia. Next slide. I think that might be it. Yeah, it's just a bit on the funding, and then ready to take questions.
Thank you, Nahid. With no questions so far in either the chat or the Q&A, so just, I know that Nahid has to leave, so if you can type quickly, we'll give you a few seconds to put any questions in. And I think otherwise, just remains to say thank you very much for a very, very clear and concise presentation. I think we'll move on to our next speaker, who is Harriet Demnitz-King from Queen Mary.
Thanks very much.
Thank you. Yes, I'm going to present some of our work around developing policy recommendations for dementia risk reduction. So Nahid covered some of the background, but briefly, dementia is a global public health challenge, with the number of people living with dementia, including in the UK, increasing. And this has a major impact on our health and social care systems, as well as the wider economy. And again, as Nahid mentioned, there is currently no cure for dementia, so prevention is a key focus. There has been kind of a wealth of epidemiological evidence linking certain factors with increased dementia risk, with the Lancet Commission identifying these 14 risk factors and suggesting that they account for 45% of dementia risk. But whilst there's this kind of growing evidence base around dementia risk and reduction, kind of translating this into effective and equitable public health policy is a major challenge. So what we aim to do was to convene a multidisciplinary group of experts to collaboratively develop and agree upon national policy recommendations for dementia prevention. And we did this through a workshop and modified Delphi survey. So to start this, we formed a steering group, which was led by myself and Professor Charles Marshall, with steering group members who are part of our policy research unit, including Rosemary Phillips, who's one of our patient and public involvement leads. And one of our first goals as a steering group was to identify relevant stakeholders to take part in this process. And we really wanted to ensure we were getting representation from multiple different fields and areas. So we convened a multidisciplinary group. So there were over 40 of us with diverse kind of lived, academic, clinical, policy and advocacy experience. And we made sure there was representation for people at various career stages and that we were diverse both in kind of gender and ethnicity too. Before we held a workshop, we held a couple of focus groups, and these were led by Rosemary, and she met with our lived experience community to see kind of what was important to them, and their discussions really focused around kind of public health messages, around dementia risk reduction, and what might motivate others to adopt lifestyle changes. And the kind of data from these focus groups were presented at our workshop and kind of informed quite a lot of our discussions. So we met in October last year. So there were about 40 of us that met for a 2-day in-person workshop, which included around 16 presentations from different experts in the field and a lot of group discussions to think about what policy recommendations we can propose based on the current evidence base. At the end of this workshop, Charles and I kind of sat down to develop the first kind of iteration of the policy recommendations. We presented them to the group and got some initial feedback and made a couple of additions and changes. And the resulting kind of policy recommendations we kind of put into Qualtrics, and we ran a 3-round online survey asking everyone who was involved in the workshop to rate how strongly they agreed or disagreed with the policy recommendation. So this varied on a 5-point Likert scale, and people are also asked to put in kind of free text response to say how they might change it and what they agreed or didn't agree with. And we use this to iteratively refine our policy recommendations. And we kind of did this through 3 rounds until we got a set of recommendations, which over 2/3 of the kind of group agreed upon, and that's when we kind of determined consensus. So after that process, this resulted in 56 evidence-informed policy recommendations that kind of fit into 4 key categories. I don't have time to go through each of these recommendations, but I'll provide an overview of kind of the key messaging that came out. So there were a lot of recommendations around public health messaging and the importance of this, with the overarching kind of theme being the need to provide clear, actionable and targeted advice for reducing dementia risk that begins in midlife at the latest, and not just focusing on older adults. For individual level interventions, we found agreement that we need to seek evidence-based interventions for individual risk factors, but there was no consensus on which risk factors matter most. And actually, this was the area we had the least amount of agreement upon. In comparison, we had really strong agreement for population level interventions. and the fact that dementia prevention should be embedded in cross-government health strategy. So it's not just for the Department for Health and Social Care. We need to engage with other departmental organisations to think about kind of air pollution and education. And then finally, we had a lot of consensus around research commissioning. So really the need for a stronger evidence base, it's essential for helping us to refine the public health messaging and the interventions that we can offer. But what really came out across all of our policy recommendations was the need to consider health inequality. So we don't want to be proposing policy recommendations that exacerbate kind of existing disparities. So just to kind of summarize to where we are now, so we've kind of taken all of this work, we've written it up for a peer-reviewed publication that will be published in early January. And this details all of the 56 policy recommendations and how we got there and the level of consensus. We've written a policy brief and shared that with different people within the government, and have also presented at different conferences. And now we're looking to kind of continue building on this work through advocacy and looking at how we can kind of do some research to fill the gaps that we identified. So again, this is just the acknowledgements that we are funded for DePRU-QM, and happy to take any questions now or via email. Thank you.
Brilliant, thank you. You've enthused the audience, and there's a question in the chat about taking part in these workshops. Now, I'm assuming because this work's going to be published very shortly that it's complete, but can you say anything about how people can get more involved with the work of the Policy Research Unit?
Yeah, so this work is now being completed, but if you go to our website, which I think we might be able to put a link in the chat, if you can sign up to be part of our kind of lived experience group, and also our newsletters, so that you'll be updated with any activities and opportunities to get involved in the research we're conducting. Yeah, very happy to hear from people.
And that link is already in the chat
right, thank
for
you.
you there. So another question about what you mean by midlife. So what age are you referring to?
Yeah, so we didn't specify this exactly. So we were initially using the kind of categories that the Lancet Commission used for early, mid and late life. But generally, it was just to highlight that we shouldn't just focus kind of the public health messaging in older adults. We really need to start earlier. And there were also discussions about how we can bring education into schools and yeah, try and engage people throughout the life course rather than just later in life.
Great. Well, thank you very much. If this is a little fast and furious today, so if you do have questions, please feel free to post them in the chat afterwards. We will try and address them after the webinar. But thank you very much, Harriet. Our next speaker is Dr. Magdalena Walbaum from the London School of Economics, and she's going to talk about preferences for new models of care.
Thank you, Barbara. Yeah, so you should all see my slides, right? Is that okay? Well, thank you for joining the webinar. So I'm going to present the work on the preferences for new models of social care for older people with high care needs in England. So I'm part of the team, which is formed by Michela Tinelli, Martin Knapp and Raphael Wittenberg. And we did this as part of the Healthy Aging PRU. So the aims of the project was to understand the current preferences for new models of social care for older people. We also wanted to explore the variations by different groups, like demographic and socioeconomic groups, and also needs-related factors. And also to explore the strength of the preferences between the different characteristics of these social care arrangements. So the project was a two-phase project. The first one was mainly qualitative work where we had lots of focus groups with the general population and also specific subgroups, where we started to explore what are the key elements that we should start including in our work based on their the importance that they gave to those characteristics of care models. And then we conducted a survey of people aged 50 plus in England. So we had a big sample size of around 2,000 people, and we had different quotas to try to achieve a nationally representative sample, which we did. Compared to the census data, it was very representative. We collected lots of information about demographics, socio-demographic characteristics, location, experience of care, being a carer, and of course, questions about their preferences for different models of care. We also conducted a discrete choice experiment to explore the strength of the preferences between different characteristics of the care models. I'm not going to go into much detail about the methods, but again, I have my email. We can put it in the chat, so we're very happy to answer any question and also have a follow-on about the methods that we used. But I'm going to present the key findings of the survey and then on the DCE. And as expected, we found that 40% would stay in their own home with appropriate adaptations if their care needs would increase. And then if they had to move to another home, 30% would move to another house or flat more suitable for their needs. So like that's the term that we find, the right sizing or downsizing. And 14% would move to a community setting. And also, as expected, only 3% would move to a residential care or nursing home. We also asked about the importance that they gave to having access to different community assets and living near those community assets. And in general, women attached a higher importance to having access to those community assets. And also we found important differences between ethnic groups. So this is one example. So all ethnic minority groups attach significantly more importance to living near places of worship compared to white British people. I'm not going to go through all these findings, but importantly, there was a social gradient in terms of the access to having enough information about their care choices that we have between different socioeconomic groups, with people of higher income having more information about their care, and also attaching more importance to having the substantial choice and control over their care and support that they would need to receive. There were also differences by age and gender and other differences that you can find out in our report and hopefully our paper that will be published very, very soon. And then in terms of the findings of the DCE, here we could quantify the strength of the preferences between these different characteristics that we asked, and also the trade-off that people would give between the different characteristics. So in general, for all the respondents, the primary factor that influenced the people's choices was who provides support with their care tasks. So respondents in general preferred receiving support from care workers arranged by their local authority compared to receiving care from their family members and friends only. Then this was followed in order of importance by receiving care from someone who respects their beliefs and values, and then their housing settings. So with a preferences for living in their own home with appropriate adaptations. And then not wanting to use assistive technology to support their independence. And then and last would be the closer access to community facilities. But then when we did some subgroup analysis here, I'm presenting just the results of when comparing the older groups, so 70 plus, there was variations in these preferences when compared to the general, the survey group. So here, for example, as you see, the housing setting had more importance than the provider of care came second, and then the access to community services would come third, respect of beliefs and values, and then the last would be the use of technology devices to support their independence. So as a conclusion of the work, what we found is that the one-size-fits-all does not fit all. And there are several differences and variations between different socio-demographic groups that need to be incorporated and be able to provide flexible care models to accommodate all these varying preferences across the different groups. And also importantly, all the different the social gradients in terms of access to information and knowing what the choices are. So we need to ensure that there is equitable access to all this information about their care choices so that they could make more informed decisions about the choice, about the care that they could receive and therefore support their independent living. Thank you.
Thank you, Magda. We again don't have any questions in the chat, so we have posted a link to the publication and report. So if anybody wants to know more, please click on those links and also get in touch by email if necessary. So thank you very much, Magda. The next speaker will be Alex Hall from Manchester University, and Alex is going to talk about quality of care in home care.
Thank you very much, Barbara. Thanks everybody for coming along today. This piece of work is about the meaning of quality in home care. So what people think of when they think of quality home care for older people. So it's quite a broad piece of work, and we wanted to explore this by reviewing international literature on home care. So the aims of this piece of work were to summarise the meanings of quality of home care for older people that are held by different stakeholder groups. We wanted to look at similarities and differences between different groups' views of understandings of quality of home care. We also wanted to identify from this literature which measures of quality might be used around home care for older people. So you probably may well be familiar with this background, but in the UK, we know that there are some enduring challenges within the home care sector. So back in 2012, the CQC conducted a major inspection programme, which found numerous challenges related to things like care planning, workforce training and support, gaps in knowledge, timing, and the sort of the time that people have to provide care. And these issues have kind of persisted to an extent, really. So generally, home care seems to be quite an unattractive sector to work in. High use of 0 hours contracts, high turnover, questions about pay and conditions, etc. This is a busy slide. I'm not going to read anything at length off this, but you probably know that the CQC has an interpretation of quality via a whole load of minimum standards about aspects of care. And there's also a new assessment framework in place that incorporates 50 we or I statements to try and assess the quality of care. Key point at the bottom of the slide here is that from these ratings a couple of years ago, the vast majority of home care services are rated as good. Very few reach the top outstanding rating, but also very few are rated inadequate. So that's just something to bear in mind. So there are many different groups of people who might have different views on what is meant by good quality care. So I think it's important to look at to what these views might be and to consider the extent to which these views might be compatible with each other. Are they shared? Are they debated, etc. So I won't go into detail about the methods that we used, except to say that we took an established academic approach to reviewing literature. We looked at international academic research, and we also looked at reports published by major UK organisations. We were interested in literature that conveyed anybody's views about the meanings of quality in older people, in older people's home care from high income countries only. So we screened around 5,000 articles and included just under 100 from 16 countries. In addition to the UK articles, there was quite a lot of work from the Nordic countries, which we would expect to see given their care systems and history of work in this area. Most of the articles focus just on home care for the general older population rather than specific subgroups. but about a quarter of the articles focus specifically on home care for people with dementia. And many articles covered the views of multiple groups of people within the same paper. So the views of older people were captured in 46 articles, the views of family were captured in 19 articles, and so on there, you can see from the slide. So we looked at across all of these articles about what they were saying about quality, and we grouped them into what we thought were four very high level dimensions of quality. So I will summarise each of these briefly. So the first dimension was about the issue of relationships. So this was covered in just under half of the papers, captured all main stakeholder groups. And fundamentally, it's that good quality care is about the development and maintenance of relationships between care workers, older people and families, usually seen to involve some sort of continuity of care. Some articles did highlight challenges for home care staff in terms of negotiating boundaries. This issue of being part of the family on the one hand, but also not being too close on the other could be quite difficult. But generally, yeah, the idea of relationships is really important to quality of care. The second dimension was the idea of good care as being bespoke. So this was our word. We deliberately used the term bespoke care. You may be thinking of person-centered care, which is the ubiquitous term. This can have lots of subtly different meanings, and we weren't able to sort of interrogate those in depth. But fundamentally, this dimension is about person-centered care. It includes references to compassionate, empathetic care that facilitates choice control, maintains dignity and independence. There were some divergent views here about the extent to which older people might want to be involved in decisions or may not voice their needs and desires. Some views from managers about home care being able to meet people's needs, but not necessarily their wants. But this distinction between needs and wants was not clear. But generally, yes, this idea of a sort of bespoke person-centered approach to care was unsurprisingly seen as being very important. The third dimension was about the organisational and structural aspects of care. So this is the largest and most complex dimension. And it's really about good quality care involving sufficient numbers of well-trained staff who are suitably skilled, appropriately remunerated. They're given the flexibility and time to deliver the care that people need. But it's also about wider structural issues in terms of older people and families being able to find information about care options, being able to navigate care systems, and wider structural aspects such as the integration of home care services within wider health and care systems. And there are clear overlaps with the first two dimensions, because in order to achieve care that promotes good relationships and is bespoke and person-centered, clearly you need some of these organisational and structural aspects to be in place. And the final dimension was where quality was seen in this literature as being a measurable construct. So this was primarily a view of managers, care providers and researchers themselves, rather than older people and families per se. But in this literature, we identified 13 instruments measuring quality. They all focused on aspects such as general satisfaction, responsiveness to need, personalisation, relationships, communication and dignity. But the point at the bottom there is quite interesting. Some studies reported uncertainty among managers and providers about what data to collect. So measuring quality is seen as being really important, but not always clear how best we should do it. So to sum all this up, we have very clear, consistent, widely held views about what quality of home care for older people means. It's about good relationships between people, linked to continuity of care staff. It's bespoke, person-centred. It has certain aspects of staff pay and working conditions and training that need to be in place. And it's about the sort of wider infrastructure and the connection of home care services to other organisations within the health and care infrastructure. It should be measurable, but it's not always clear how we should do this. What was less clear from this literature is how we actually achieve care that fully aligns with these views. So how do we do this in the context of financial and resource constraints? We know less about whether people feel they actually get quality care, how they articulate what they want, how they complain if they're not happy with care, what happens if they complain. There were some groups' views not captured in this literature, so we didn't find anything on the views of commissioners, for example, but this might be because we were looking specifically at work around older people's home care, and commissioners' views may be captured in work that looks at home care more broadly. And we think finally that there needs to be some international consensus on measurement that captures these understandings of quality, but in a way that's not too burdensome. So I will end there, and that should lead us nicely onto the final presentation from Vanessa. There is more information on our website, and this is in a peer-reviewed paper that was published last year, so it is widely available. Thank you.
Thanks, Alex. So the links to the publication are again in the chat for anyone who's interested. There is a question which is a point of clarification about whether the review considered care that was provided to someone using a direct payment or personal budget. So
not specifically. The issue, some issues around payment and funding did come up in the third dimension around organisational and structural aspects of care. But I think one of the challenges of doing a review like this, when we're looking internationally, is that there is a lot of variation in terms of care systems, in terms of structures and funding. So we did not look at that particular issue in depth now.
okay, thank you. It's great. Well, I think we will move swiftly on to our final speaker because we're keeping neatly to time. So this is Vanessa Davey from Newcastle University, who's going to talk about minimum data set for home care.
Hi, thank you, Barbara. Can you see my slides correctly? Yep. Okay, so I'm Vanessa Davey from Newcastle University. I'm here to share findings from our study on what should be measured in a minimum data set, or MDS, for home care. So this work builds on the DATCHA study, which looked at developing a minimum data set for care homes, but focuses on the quite different but much less visible context of care, which is delivered in people's homes. So, as Alex has already mentioned, there are a great many people receiving home care in the UK, and very little is known about who they are. There's no consistent data across services, and this creates an enormous visibility gap for people who are planning or commissioning care services, but also for anybody across the health and social care system who are trying to understand how to support people to live better in their own homes for longer, which ultimately is very much the emphasis of the NHS long-term care plan. And the introduction of digital social care records across services, including care homes and home care, has raised the agenda of the possibility of introducing a minimum data set system across these areas to try to tackle some of these issues. So our aim was to explore the potential content for a minimum data set for home care, looking at what would be feasible and meaningful and what would reflect the realities of home care. And we focused on two particular areas for a scoping review to unearth potential tools that could be embedded, which I'm going to talk to you about. So most of the standard or core domains that had developed have been developed for the DATCHA care homes MDS. They adapt reasonably well and could be, with some simplification, embedded within home care MDS. But there are two critical areas here that you see, which are important in home care settings, and those would be unpaid care and the home environment. So those areas in particular, as I mentioned, essentially are the most invisible aspects of care. Unpaid care is, So unpaid care, we believe, is extremely important because it can it can affect the outcomes of care. Unpaid carers provide a huge amount of care input, which both complements and substitutes for what home care carers would otherwise have to do, or other sources of paid care. And the home environment, as we know, is not a structured or formalized setting, and there can be huge variations in the home environment, which can really affect and determine the outcomes of care. So we undertook a scoping review to look at potential measures for the home environment unpaid care, which until now have not been used in any formal or routine way of measuring data in home care settings. So regarding the home environment, we've found 20 tools. They looked at common themes, hazards, utilities, adaptations. They also featured aspects such as comfort, safety, clutter. We found that most of these tools were very much derived from the academic disciplines from which they were derived. So we had tools which were derived from occupational therapy areas, and the tools which derived from gerontologists. The gerontology-focused tools emphasize things such as the comfort, meaning, and personal perception of home rather than physical features, whereas the occupational therapy-derived tools look very much as safety and risks, etc. But essentially the big issue with all of these was that they were far too long and too specialised to be considered feasible for a home care environment. So this is just a quick map that we did so that you can see how these tools compared across the different areas that we mapped them against. So what we did find is that there are some short tools regarding unpaid care, such as the tools which are used in traditional surveys, such as ELSA and the census, and they capture core features such as the number of hours or the intensity of unpaid care that is provided, although they capture this in slightly different ways. Also whether or not there is an unpaid carer present or not. And also some of them include things such as caregiver distress or caregiver burden. But there's an enormous amount of variation in all of these things. And as I've said before, none of them are measured or routinely in home care as such. So we also spoke to stakeholders about how they would feel. So despite the fact that data is routinely being collected now to a much greater extent by digital means, all of these domains that we've been focusing on all would be an introduction to things which are not necessarily already collected. So we spoke to them about their priorities. They felt that capturing data on clients' quality of life, nutritional status, unpaid care and the home environment would all be really important. They're aware that things like aspects of the home environment can impact on caregivers' workload. It can impact on safety, feasibility, the amount of time, moving things which are incredibly cluttered and overloaded with furniture can make caregiving more risky and more burdensome. And also they're aware that somebody's home environment is also an important determinant of their kind of health and well-being. And they're also obviously very sensitive to the amount of support that unpaid carers provide. However, they did feel that many of these things really needed to be treated with sensitivity. They said to us, we don't want to be asking sensitive questions around, for example, how much an unpaid carer provides unless they're really essential and benefit our clients. But they did believe that these types of areas, that talking about these types of areas and recording this kind of information would be important. And their request was this would align with digital systems and reduce duplication for information that they're being asked to collect and record for other sources. They stressed the clarity of purpose, how data would be used, avoiding disruption to care relations and piloting before full implementation. above all of the work that we did with stakeholders underlined the importance to everybody of making sure that care becomes visible. And that there was a lot of comments around some of the nuances that are happening very much on a daily basis in care, such as delegated health tasks, and that this lack of understanding of what makes up care in home environments could be tackled by a minimum data set for home care. So what could work in practice? Short validated questions, such as those which may be already being used in national surveys, starting small with a kind of core set that we could then potentially add to, aligning it, as I said, with digital care systems, piloting it with a small number of providers or local authorities, making sure that all of the measures that go into it are co-designed, and making it clear why the data is being collected, how it benefits care, and making sure that everybody who is involved, especially home care providers and people who are receiving care, that agree with why this should be collected and what it's being used for. So our last thoughts. Finally, just to say that to understand care at home, we really believe that you need to measure both the place it happens and the people who provide it. Thank you very much.
Thanks, Vanessa. Again, we don't have any questions in the chat, but so it just remains me to say a huge thank you to our speakers for being clear, concise and keeping to time, and for all of you for coming along to listen. We hope you found it interesting, stimulating. Please have a look at both our websites where you'll find all our work that's been presented today and a lot more. Our next webinar is in the series is on the 17th of December, and it's going to be focused on longer working lives, exploring the impact of raising the state pension age on health and well-being. So please do come along to that. But again, thank you very much for coming today.